So, hello, everybody. I think we can get started now. Um, I really would like to welcome you to this special program this evening. My name is Emily Von Shaven, and thank you so much for taking time to join us for this program about COVID and children. So I'm going to be introducing tonight's featured speaker, Dr. Erica Lawson, and I'll be moderating the question and answer period at the end. But before Dr. Lawson starts her presentation, I just want to tell you a few things about myself and about this educational series. So I'm a pediatric rheumatologist, like Dr. Lawson here at UCSF. I take care of children with all kinds of rheumatic diseases, and I serve as the director of the Division of Pediatric Rheumatology. And tonight's educational program is hosted by the Russell Engelman Research Center and both the divisions of adult and pediatric rheumatology. I'm really pleased to work very closely with the adult rheumatologists and with the Russell Engelman Research Center, whose mission is to support rheumatology research and education here at UCSF. So this series that you're part of was developed to provide free educational programs for patients with rheumatologic conditions and their families and friends, as well as many others who support our work. And we're really happy that you're joining us this evening. The educational program covers a variety of topics, and today we're lucky enough to have a pediatric speaker. And Dr. Erica Lawson will be educating us about the impacts of COVID on children and telling us about this newly described condition called Multisystem Inflammatory Syndrome in children, which is abbreviated MISC. Dr. Erica Lawson is an associate professor of pediatrics at UCSF. And in addition to providing medical care for children with rheumatic diseases at our two affiliated children's hospitals, the Benioff Children's Hospital in San Francisco and the Benioff Children's Hospital in Oakland. She's also served for many years as the program director for the Pediatric Rheumatology Fellowship Program, which is training pediatricians who want to become pediatric rheumatologists. Tonight, I encourage you to submit questions via the question and answer function on your screen, not the chat, the question and answer function. And then we're going to try and get to as many of your questions as we can during the last 20 minutes or so of the presentation. And so we really look forward to her presentation and to answering all of your questions. I also just wanted to let you know that we are being recorded. But your faces will not be captured on the video. Only the speakers, Dr. Lawson and myself, will be seen or identified on the final video. So thank you so much again for being here this evening. I'm going to turn it over to my colleague and friend, Dr. Erica Lawson, who will start her presentation.
All right. Thank you so much, Emily, and welcome to everyone. It's a pleasure to get to talk to you tonight about something that I've spent a lot of time thinking about in the last couple of years, which is COVID and MISC. So you'll learn in a little bit why this presentation is titled COVID Strikes Back, because multisystem inflammatory syndrome in children, or MISC, is a late manifestation of COVID infection. So I'm sure everybody remembers very well the winter of 2020. So starting around New Year's, we began hearing something, in the news about maybe there's some pneumonia in China, somewhere very far away. Nobody died yet, not sure what's going on. And then all of a sudden in March, everything changed. And I'm sure you all remember where you were when it just became clear that the world was going to change in a very major way. I remember the night of, Wednesday night, having a trip planned actually to visit some friends, and making the decision on Thursday morning with my bag fully packed that I was not going to the airport because all of a sudden we were hearing that there was going to be lockdowns. And then I remember the very next day I was at the hospital and getting the email that my children's school was closing for 2 weeks. And it's funny looking back how that felt extremely catastrophic as a working parent, that my children's school was closing for 2 weeks. What on earth were we going to do? Little did we know what was coming. So that April, I was spending a lot of time in the hospital with one of my fellows, Dr. Soulsby, and the two of us, I remember we were laughing at each other because we were Purelling like every 10 feet. We would walk from one room to another, Purell again, one room to another, Purell again. And we were all getting used to wearing masks all the time, which, you know, normally we were used to maybe putting on a mask occasionally for a patient who had a viral infection just to decrease transmission, make sure that we didn't get it. But suddenly we were wearing them all day long. But more than anything, we were so worried about our immunosuppressed rheumatology patients, all the children that we take care of, for whom we prescribe immunosuppressive drugs, knowing that there was this new infection out there and we weren't sure how it was going to affect them. So we started to learn about the symptoms of COVID-19. And the common ones seem to be fever, dry cough, people get very tired. Early on in the pandemic, loss of taste or smell was very common. That's become a little less common with the current variants. Regular cold symptoms like sore throat, nasal congestion, red eyes. People would also get headache, muscle or joint pains. Stomach symptoms were not uncommon, and then dizziness or chills. But then some patients, some folks would develop severe symptoms. So we would also hear often, you know, around 10 days into the infection, with persistent fever, that suddenly the fevers would get worse. Individuals would develop shortness of breath, not being able to eat, chest pain, confusion, needing to go into the hospital. And then there were rare symptoms, a lot of them neurologic. So things like becoming irritable, seizures, having mood changes like anxiety or depression, sleep problems, and then some patients who even developed clinical brain inflammation, stroke, or nerve damage. So this is a picture of the coronavirus that causes COVID-19, known as SARS-CoV-2. And you've heard probably about these spike proteins, which you can see here on the virus. So coronaviruses get their name from corona, which is Latin for crown, because they look like they are wearing a crown with all these proteins sticking off the outside. And the way the SARS-CoV-2 virus grabs onto human cells is by the spike protein attaching to something called an ACE2 receptor. And that'll be important in a little bit. But I'm going to talk a little bit just about how this virus gets into the human body. So when the virus spike protein latches onto the receptor, there's this ACE receptor right here. There's this protease, which is another enzyme that cuts proteins. So it cuts the cuts the spike protein in half right here. And inside of the spike protein is another protein that's all squished up like a spring. And so once that top part of the spike is opened, the spring here pops out, and you get this machinery that attaches itself to the membrane of the cell. It then pinches those membranes together, and the virus particle is actually able to fuse itself with the outside of the cell. So picturing like a little cell inside your nose. And all these strands of RNA, which is the genetic material that codes the COVID virus, pours out here into the cell. And finally, the virus's most important job after it attaches is that it needs to make more copies of itself. So what it does is all the RNA genes travel to the cell's ribosomes, which are little protein-making factories. Some of you may remember this from your basic biology courses. And so these are the little dots you see here on the outside of this squiggly thing called the endoplasmic reticulum. And the RNA codes for these proteins, which then get processed into these little circles here, these bubbles called vesicles. And these guys inside here are able then to make more proteins, more copies, and duplicate the virus. And then eventually these become virus particles that break out of the cell. All right, so let's talk a little bit about COVID-19 specifically in kids. So many, many kids in the United States and around the world at this point have had COVID. About 20% of all kids in the United States, representing about 19% of the total number of cases in the US. But what's different about kids with COVID is that they often have minimal or even no symptoms. And because of that, there are likely far, far, far more cases that have actually occurred out in the world than the number that we have reported. We also know that COVID is less dangerous, as I said, in children. So kids account for somewhere between 0.00 and 0.26% of all COVID-19 deaths, a tiny proportion. And again, remember that they're about 20% of all infections. Similarly, somewhere between 0.00 and 0.02% of all child COVID-19 cases have resulted in death. Again, very grateful that this is a tiny proportion. There are 3 states that have actually reported 0 COVID deaths at all from COVID, 0 child deaths at all from COVID. But what we do know is that the children who are most likely to have a severe course of COVID are those who have neurologic disabilities or those with multiple chronic conditions. So those are the kids who are at higher risk. So why is it that kids don't get as sick with COVID-19? And while we don't know the answer to that exactly, I'm going to go through 3 hypotheses, 3 possibilities that scientists are studying. So one possibility is that is due to a process called antibody-dependent enhancement and immune complexes. So antibodies, you may know, are a part of the immune system. And when the immune system is activated, these antibodies can glom together, as you see sort of demonstrated in this picture here, creating things called immune complexes. So kids get sick a lot. And with, a lot of times when they get regular colds, it's with garden variety seasonal respiratory coronaviruses, which are not the SARS-CoV-2 virus, but are related. And so there's a hypothesis that kids may have higher titers of these antibodies to other seasonal coronaviruses, which then might cause them to be able to get rid of the SARS-CoV-2 virus more quickly and more efficiently. On the other hand, older folks may have lower titers of antibodies because they haven't been sick as much as recently. And therefore, they're not as able to remove the virus. And they have this ongoing immune activation causing the formation of these immune complexes, which can result in tissues damage. So immune complexes like to settle into tissues and blood vessels and cause inflammation. That's a problem that we as rheumatologists are very familiar with, that we see, very prominently, for example, in lupus. And so there's a similar process at play here. The second hypothesis has to do with the role of that ACE2 receptor, which you'll remember is where the spike protein joins up with the human cells. And here's another picture of a SARS-CoV-2 virus particle with all these spike proteins on the outside binding to this ACE2 receptor. So younger people have fewer ACE2 receptors in their noses, making it harder for the virus to enter cells. So the kids might get infected, but maybe they don't get as high of a viral load, and therefore their illness is less severe. And the third hypothesis has to do with recent vaccinations and a concept called immune senescence, which is basically an elderly immune system. So there's a thought that recent vaccinations, as you know, kids get, typically lots of regular childhood vaccinations against other pathogens might provide some degree of cross protection against COVID-19. In addition, even in kids who are vaccinated against COVID-19, maybe some of their other vaccines are actually also helping to provide some protection. On the other hand, as folks get older, their immune system also starts to wind down. And their T cells, which is another part of the immune system, have less versions of themselves. They're less likely to identify a new pathogen. And therefore, again, the virus can replicate more, leading to more tissue damage because the immune system is just not catching it as quickly or as getting rid of it as robustly. All right. So coming back to March of 2020, as I mentioned, we were super, super worried about our kids with autoimmune diseases, but we actually found that we had another problem on our hands because we started seeing increased numbers of these really severe cases of a condition, what we thought was a condition called Kawasaki disease, coming into our hospital and coming into other hospitals around the world. And there were quickly a couple of publications that came out about this. You'll see also in really the spring of 2020, outbreak of severe Kawasaki-like disease at Italian epicenter of the SARS-CoV-2 epidemic, and hyperinflammatory shock in children during the COVID-19 pandemic. This second article is out of London. And you'll remember that these are places in Europe where the pandemic had its biggest early surges. And so these are some of the first articles that came out. And what we saw is that these severe Kawasaki-like disease-like cases were presenting in places that had a very high burden of COVID infection. And so what we learned during that spring is that there are two phases of COVID-19 in kids. There's the acute COVID infection. These patients typically have a positive PCR test, which means you can find actual virus particles in their nose, and it presents at the beginning of the infection. So you have the typical symptoms that you expect to have with an acute COVID infection, and in kids, the illness is often mild. MIS-C, on the other hand, which was what this Kawasaki-like presentation was, is a late presentation. So these kids were showing up 2 to 6 weeks after their infection. And often we would see a surge of these cases 2 to 6 weeks following a big surge of COVID in a given geographic location was what we started to notice. There were features overlapping with Kawasaki disease, but also some things that were different, and we'll talk a little about that. And these kids were very, very sick. So the CDC, as quickly as they could, put together a case definition, and you'll see it's very broad, which really has to do with this being an early stage when we didn't have as much specific information about what was going on. So you had to be in order to be diagnosed with MIS-C, you had to be less than 21 years old. You had to have a fever for more than 24 hours. You had to be so sick that you needed to be hospitalized. On blood testing, there needed to be evidence of inflammation. You needed 2 or more organ systems involved. So for example, GI involvement and skin involvement with a rash. There needed to be no alternative diagnosis, say like another infection that was not COVID. And there needed to be some evidence of a current or prior COVID infection or a known exposure within the past 4 weeks. So let's talk a little about what we know now about MIS-C epidemiology. So this is not a common condition. We've had 316 cases per 100,000 COVID infections among those less than age. This is just among people under 21. We also know that the epidemiology of MIS-C tends to mimic the epidemiology of COVID itself. So we've heard a lot about all of the disparities in COVID infections in the United States with higher incidence in Black and Latino populations in particular. And similarly, we saw and continue to see higher rates of MIS-C in Black, Latino, and Asian populations. There also seemed to be a lower incidence among the older kids as compared to those 5 and younger. So this seemed to be something, even though we were seeing it across the spectrum, and we'll talk a little more about the ages affected, we did see a little more of a prevalence in the younger kids. So let's talk a little bit about Kawasaki disease to tell you a bit more about the story of how we figured out what this disease was and how we became involved as rheumatologists. So Kawasaki disease was originally called mucocutaneous lymph node syndrome, and you'll find out why when I show you some pictures. This was first described by Dr. Kawasaki among Japanese children in 1967. It's a form of vasculitis, which means inflammation-itis of the blood vessels, vascular. Kawasaki disease in particular affects the medium-sized vessels, and what it's really known for is affecting the blood vessels in the heart, and that's why this is a condition we have to take pretty seriously. However, unlike many other diseases we take care of as rheumatologists, this is a self-limited condition, so it burns itself out and goes away and does not recur. And it's a disease really of young kids, so 80 to 90% of cases occur in children 5 and younger. And one of the things, as a physician that I think is really fascinating about this condition is it has a lot of very distinctive physical findings. So the way that you diagnose it is really by looking at for these particular findings. So you have swollen feet here, you have these red eyes, And the red eyes have a particular feature that you can see in this picture called limbic sparing. So this area right along the edge of the iris here is called the limbus. And you can see there's more intense red here, less so here. So conjunctivitis, which is inflammation of the conjunctiva, layer of the outside of the eye, with sparing of that limbus. You also have some really interesting features in the mouth. So you have something called strawberry tongue. And you can see how this tongue, the papillae, the little bumps on it are really prominent, and it looks pretty bright red, kind of like a strawberry. And you can also get really swollen, red, cracked lips. So you can see this little child here has quite red lips, and you can see some evidence of flushing and rash on the face too. The rash very commonly affects the whole body, and the trunk is really prominent. So you can see that here. And then finally, there's a late finding of Kawasaki disease. It's again very specific to this condition where so after this early redness and swelling of the hands and feet, about 6 weeks after they get better, they tend to have peeling on their hands. All right, so I mentioned that one of the most important and most serious features of Kawasaki disease is the fact that it affects the blood vessels of the heart, known as the coronary vessels. And it specifically causes these things called aneurysms, which are outpouchings created in the vessel wall due to weakness. And that weakness is caused by inflammation. So this is just a drawing here showing you what the blood vessels look like when there are multiple aneurysms affecting them. And then this is a picture actually from a cardiac catheterization. So this is a procedure where you put in an IV, you insert contrast, and then use an X-ray to actually be able to look at the blood vessels in the heart with the contrast lighting them up. And this gives you an opportunity to really see where these arrows are, these big outpouchings here. And we worry about coronary aneurysms because they can lead to clots, which can actually cause heart attacks in very young children. Fortunately, this is a rare complication of Kawasaki disease, but it is something that we have to think about and keep an eye on. So we found there were a lot of features of MIS-C and Kawasaki disease that were similar. So kids with MIS-C and KD are coming in with red bloodshot eyes. Some of the children with Kawasaki or with MIS-C would also have those red cracked lips and red tongue. They both have quite high fevers, sometimes even up to 104. A rash that can involve a lot of the body, and then the swollen red hands and feet. And these are some of the features, that I showed on the previous page that they have in common. An additional one includes swollen lymph nodes in the neck, which is something that you can see in both. But there are some important things that were different. And this was really critical to us as rheumatologists as we were figuring out how to tell, was this Kawasaki disease, was this MIS-C? So Kawasaki disease is more prominent in children of East Asian ancestry. And I mentioned that most kids are under 5 who have KD. As on the other hand, we talked about the fact that MIS-C really reflects the demographics of COVID infection. So more folks of African and Latino ancestry. And we also saw that MIS-C really seemed to affect a broader age range with a bit of a predilection for the younger kids, but many more cases in children over 5 than we would typically see for Kawasaki disease. So that was an important clue. There are also some differences in the clinical manifestation. So kids with MIS-C very frequently had stomach flu type symptoms, whereas in Kawasaki disease, that's really quite rare. Kids in MIS-C, as I mentioned, also are often very, very sick when they come in. So they would have low blood pressure, high heart rates, breathing fast. They would sometimes need extra fluids, medications to bring their blood pressure up to a safe range. We do sometimes see shock in our Kawasaki patients, but it's really quite rare. We were seeing much more shock than we typically would see. Another thing that's different, so we just looked at some pictures of the typical way in which KD affects the heart, which is through the coronary inflammation of the coronary blood vessels and these aneurysms that develop. And we do see some of that in MIS-C, but we see a much broader range of ways that MIS-C affects the heart. So these kids would also have myocarditis, so inflammation of the heart muscle leading to abnormal heart rhythms and abnormal squeezing of the heart, so heart failure. There's some important differences on labs too that were a good clue for us. So in Kawasaki disease, you typically see an increase in platelets, which are blood cells that are important for blood clotting, whereas in MIS-C, we found that they tended to fall. Lymphocytes, which are an immune cell, are typically normal in Kawasaki disease, but we noticed a trend in MIS-C patients that their lymphocytes would be low. And interestingly, that was also a finding that was common among adult patients who are getting hospitalized with very severe COVID. And finally, their inflammation markers were super high in MIS-C. So C-reactive protein is just a generalized non-specific marker of inflammation in the blood. It's high in Kawasaki disease, but we saw in these MIS-C patients, it would be super high. So fortunately, our colleagues at the American College of Rheumatology got together as quickly as they could to help us characterize this condition and figure out how to treat it. And we had our first set of guidelines we were grateful to receive in July of 2020 to provide guidance to rheumatologists, cardiologists, critical care doctors, infectious disease doctors, who are providing care for these patients. It was really an unprecedented thing that we were dealing with a completely new disease as a rheumatology community. And it was pretty amazing to watch how everyone came together to learn from each other and to guide each other as quickly as we possibly could. Here at UCSF, we also brought together a group, a multidisciplinary group that's led by our Chief of Pediatric Infectious Diseases, Ted Rule. And we've been meeting on Fridays since this really pretty early on in the pandemic. Again, with the goal of really keeping each other informed as to what we were seeing and the outcomes for our patients. And then also working together to review the literature, whatever was coming out, to learn together as much as we could, and then create guidelines for our hospitals. And so these are our pediatric COVID and MIS-C guidelines. They have been, this is version 6.2, so you can see they've been updated continuously as the environment is changing, as we learn more, as there are new variants that behave differently from previous ones. And so starting with how we treat acute COVID-19, outpatient treatment, pre-exposure prophylaxis for patients who are at really high risk for severe disease, addressing pediatric long COVID, vaccination, anticoagulation in patients who are with COVID who are at high risk for blood clots, and finally, the diagnosis and treatment of MIS-C. So how do we treat MIS-C, and how did we figure this out? How do you treat a disease that's brand new? So because of the resemblance to Kawasaki disease, we initially decided that it made sense to follow Kawasaki disease treatment protocols. And so that's what we did. We started with IVIG, which is intravenous immune globulin, a blood product that is used to treat Kawasaki disease, and aspirin, which is also used to treat Kawasaki disease. However, about 9 months to a year into the pandemic, some interesting data started to come out showing that in patients who received glucocorticoids in addition, they had fewer days in the intensive care unit. And so that led to an evolution, a change of our treatment practices to recommend steroids up front, unless it was a particularly mild case of MIS-C. And then for patients who are extremely ill, on ventilatory support, on medications to keep their blood pressure in a safe range, we will often add second-line medications. So we will use glucocorticoids again, but at a higher dose than what we use for our first-line treatment. And then we use a biologic medication called anakinra. And this is a medication that blocks IL-1 beta, you see right here, which is a really important mediator of inflammation. And anakinra is a useful drug in that it is an effective and it works extremely fast. So it's a quick on, quick off medication, really good addition for our patients who are super sick in the ICU. So what do we know about the outcomes of these children? I've talked about the fact that a lot of them come in incredibly ill, they're in the ICU, but the great news is that most of them fully recover. So among over 5,000 cases that had been reported to the CDC as of October 21, less than 1% of those children died. And considering how sick they were at the onset, that's really an incredible thing. We did find that mortality is more likely in patients who are older and those who have comorbidities. So particularly those who have birth defects, congenital abnormalities, and those who have neurologic problems. And the other bit of good news is that these heart abnormalities that we see, so the formation of these aneurysms, the issues with inflammation of the heart muscle, all seem to resolve by 6 months in the great majority of patients. So most of these kids get all the way better and return to normal life. So vaccines could be certainly its own whole talk today, but I'm going to talk a little bit just about how they play into this story. I remember when I got my first dose of COVID vaccine right before Christmas in 2020, and I cried. It was such an amazing thing to see how medical science had come together to create this effective vaccine in such a short period of time. We had been in the hospital taking care of, sick patients, trying to keep our patients with rheumatic disease safe, and to be able to have that protection for myself and my family, it was just the most incredible feeling. And similarly, I was thrilled when not too long after our patients aged 12 to 17 became eligible for COVID vaccines. And then in November of 2020, my kids were able to be vaccinated when there was an emergency use authorization of the Pfizer vaccine for children age 5 to 11. We, as you know, are still waiting on vaccinations for our youngest kiddos. And the reason for that is it's been difficult to prove efficacy. And a lot of that has to do with the fact that the COVID infections, as we've talked about, become more severe with older age. So with the exception of our really, really tiny babies, kids in this young age range tend to do very, very well with COVID. And so it's been hard to prove that the vaccines work in this youngest group. But there's going to be a meeting in June. It sounds like Moderna and Pfizer both have some more data to present. And certainly I know we're all crossing our fingers that we'll be able to have vaccination for those youngest kids too, just to help keep them safe. As many of us have experienced, you certainly can get COVID once you're vaccinated, but the really important thing is the decreased risk of hospitalization and death. Even though this very young group has an extremely low risk of hospitalization and death at baseline, it's certainly helpful to have a vaccine too. Another reason that it's important to be able to vaccinate these young kids is this recent data that shows that these vaccines also prevent MIS-C. So data from 70 US hospital sites showed 91% effectiveness of the Pfizer vaccine in preventing MIS-C. In addition, all of the critically ill MIS-C patients who required life support among these 70 hospital sites were unvaccinated. So this may be actually the most important reason that we want to vaccinate these young kids, because it prevents MIS-C and prevents the worst outcomes of MIS-C. Another thing I wanted to talk about briefly, a lot of you probably heard about concerns about myocarditis, heart inflammation caused by the COVID vaccine. This does appear to be a real signal. It's a thing that can happen, but again, fortunately, super rare. So the highest risk of myocarditis seems to be after the second vaccination among teenage and young adult males. But in this population, the rate is still super low. So we're talking about 50 to 100 cases of myocarditis per million doses of vaccine, not a lot. I have seen one of these patients in the hospital. His myocarditis was treated with, really not super strong medications, got better and went home. And that seems to be the case with, based on reports with most of these kids, that, certainly we don't want anybody to develop a complication from their vaccine, but it does seem like everybody recovers quite well. And finally, I wanted to mention long COVID. This is certainly something that has gotten a lot of press. And I would actually make the argument that the press has been fairly inflammatory in the way that they talk about this. So long COVID certainly is a real thing, and it's affected especially a lot of adults in very profound ways. Sensory, neurologic, and psychiatric symptoms are most common. People complain about exhaustion, brain fog, temperature fluctuations, flushing. The thing about long COVID that makes it difficult is there's no clear case definition, and all the studies in kids have been pretty poorly done. So we don't have a lot of meaningful data about the prevalence. We also don't know if vaccination affects the risk of long COVID in kids, although there is some data to suggest that it does in adults. What we can say is that COVID symptoms rarely persist past 12 weeks in kids. In our UCSF COVID consortium, we have been talking very often about long COVID and sort of asking each other if we are seeing these cases coming into our clinics. And they seem to be really among a variety of different subspecialists, quite rare. So we're having a few people coming in complaining of long COVID symptoms, but not many. So it certainly seems like it is not a common occurrence, but the data needs to be better. So in summary, COVID-19 infections are very common in children, but they're not as severe as they are in adults. Multisystem inflammatory syndrome in children is a rare but quite serious complication of COVID infection that occurs about 2 to 8 weeks after the initial infection. Immunosuppression is usually effective in treating it, and the majority of kids will recover without significant complications. Vaccination is important in children, if only to reduce the risk of MIS-C. That's a really good reason to get kids vaccinated. And while little is really known about long COVID in kids, the incidence is likely quite low. Thank you, and I'd love to take your questions.
Great. Thank you so much, Erica, for a really fantastic presentation of such a complicated medical condition. You know, living through a pandemic is not something any of us ever thought we would experience. And when you were describing sort of March of 2020 and what was going on, you just brought me right back to those days when we just didn't know what to do. There were so many unanswered questions. We were just starving for information and really facing a lot of difficult decisions with no information. And I think thankfully, because of all of our collective experience and really a lot of advances in the medical research arena, we're in a much better place now. Not that there aren't still some unanswered questions, but I think maybe there's one question to get us going, and I'd encourage others to enter questions in the Q&A for Dr. Lawson to answer. But there is a question about long COVID. I know you mentioned that it's, we don't see it that much. It's not that common. But can you talk a little bit more about what we do know about it? And also this question about whether it might happen after asymptomatic infection. And I think asymptomatic infection is sort of a growing theme in the community right now.
Mm-hmm. Yeah, that's a great question. I mentioned a little bit about long COVID. I wish that we knew more, but what's reassuring, at least to me, is that in our Bay Area consortium, we are not seeing a lot of families coming in complaining of long COVID symptoms in their children. We have a handful, but not, given the amount of COVID that's out there right now, I'm grateful that we are not seeing more. But there's certainly a lot more research that needs to be done. And a lot more that we need to learn. I also really can't say much about whether long COVID can happen after asymptomatic infection. What I can say is MIS-C can certainly happen after asymptomatic infection. We've had many children who've come in super sick with MIS-C and their parents had no idea they'd ever had COVID. But in the pre-vaccine days in particular, we were able to test for antibodies and be able to show that there was evidence that they had had a COVID infection, but no one had any idea.
Yeah, there's another question about the sort of pooled testing that people were doing, and about somebody who experienced their child was tested through that approach in the school setting, and kind of how pooled testing is used.
Yeah, I mean, in terms of, so pooled testing is a way that schools are using to try to just screen for the presence of COVID among individuals in the community. There are definitely children who get, identified who do not have any symptoms. This is where antigen testing can be helpful. And you can get home kits. A lot of you are probably familiar with them, that you can buy at the drugstore, do a little nose swab and see if you are positive. The CDC guidelines recommend quarantine with 5 days after either onset of symptoms or the positive test. So quarantine at home. And then after 5 days, you can return to the community with masking. But I think the antigen test is helpful if you want a little more sort of discrete information about whether your child is infectious. It's not 100% perfect, but can give you some data.
Yeah, great. There's a question about in our patients who have rheumatic diseases, I think, can you talk to us a little bit about what it's been like for them in terms of um, development of COVID infection, what happens to them, and any manifestations of or diagnoses of MISC in kids with rheumatic diseases?
Yeah, good question. So I mentioned early on, we were so worried in the beginning about what was going to happen with our patients. Were they all going to end up in the ICU? Were they going to be super sick? And I remember over the spring and summer of 2020, hearing from, an increasing number of my patients out in the community who were getting these infections, and they were okay. They would have like a fever for a couple of days, feel a little bit lousy, and then they were fine. It was such a relief as we started to see more and more of those cases coming in, getting this sense that, okay, this may really not be so catastrophic after all. And it's really fascinating, right? Because these are kids who often have part of their immune system suppressed, but there's something about the fact that they are young that just seems to outweigh that. In terms of which kids with rheumatic diseases are at highest risk for getting sicker with COVID, so certainly the patients who classically do really well in our experience are kids with juvenile arthritis who are on methotrexate or a TNF inhibitor like Emeril or Humira, and we found those kids tend to do really, really well. Our patients who have more serious systemic illnesses like chronic vasculitis, like lupus, like dermatomyositis, and especially those who are on high doses of steroids are at higher risk for getting more seriously ill, although fortunately, I don't really think we've had too many cases. In terms of MISC in kids with rheumatic diseases, I haven't seen it. I don't know if you have, Emily. You have like rare condition, and they don't necessarily overlap. MISC, while it is cared for by rheumatologists because of our understanding of the immune system and of what happens when inflammation gets out of control. This is not a disease of kids, that it affects children with rheumatic diseases. It is a disease that affects healthy, anybody out in the community. It could be, just mostly healthy kids. So I have not, Emily, I don't know if you've seen anyone, but I
haven't either. I think it's a really interesting idea, and either it's so rare that we haven't seen it yet, or our patients are being extra cautious about not getting COVID, which we know isn't always the case, or there's something about their immune system, either because of their condition or their medications, that is not driving this picture that we call MISC. And it's also interesting how, sort of well patients have done even on immunosuppressive medications, right? And we talk about the redundancy in the immune system and how many parts of the immune system are spared even in the setting of being on these medications. So more to understand there. There's another question about the protection after vaccination and how long it lasts. And the observation that, in many of the data in adult is showing that it's not lasting, as long as people might have hoped, and wondering if annual vaccination for COVID might be something that's also in the future for kids, just like they get a flu shot every year.
Yeah, I think it's definitely being talked about. And that's actually part of what they're going to be discussing at the meeting I mentioned in June. That the CDC is having when they're going to be talking about vaccinations for the youngest kids. They're also going to be talking about what is going to be the plan for vaccination going forward, and the ways in which the existing vaccines, which you'll remember were developed right at the beginning of the pandemic, these vaccines may need to be updated, right? Because now we're on to, we're past Delta, we're on to Omicron, and the virus is evolving as flu viruses do. So I think there's a real possibility that it may be that going forward, you got your flu vaccine and you got your COVID vaccine in the fall.
Yeah. You want to just share a little bit about sort of how this whole thing has changed your practice as a rheumatologist?
Oh, yeah. I mean, so Emily knows that this is, COVID and MISC in particular has had a really profound impact on our practice in rheumatology. There have been, predictably after every big surge, I shouldn't say not predictably in the beginning, but predictably as we went, every time we would have a giant surge, especially before the younger kids had vaccines available, we would have a surge of MISC. And, as recently as really winter of 2021, the hospital was we had a lot of these kids in the hospital, and we as rheumatologists are used to, we aren't typically caring for that many kids at a time because we have, our conditions are really rare. And suddenly we were getting like lots and lots of calls, especially our practice in Oakland, which has a really high number of Latino patients, more Black patients. The populations that were really more impacted by COVID were also more impacted by MIS-C. And so that really made a big difference. And, I think also just spent a lot of time in the last 2 years talking to parents about, what we know, what we don't know, what should we do about vaccination? Do you need a booster? What is what can I tell you today? And what do I hope I'm going to be able to tell you in 3 months? So I think one thing that was, just felt very present in my practice is like being able to articulate the information that we have and then the limits of that information, and being able to say, these are my best recommendations for you. And these are the things I don't yet know, but let's talk soon.
Yeah.
This information is just changing all the time.
It is definitely changing quickly. So someone's asking about the idea that it might be better to get COVID when you're younger than when you're older. And do you think it might be good for kids to get it younger, when they're younger, because they would have mild disease and that might somehow protect them when they get older from future infection?
Yeah, I mean, that's an interesting question, but I think there are just so many, certainly most kids who get COVID do great. But I would not recommend intentional infections because, like, what if your kid ends up with MIS-C? What if something weird happens? Whereas vaccines, we just know are safe. So I would say don't get a COVID infection, get a vaccine. I also don't think there's any reason to believe that immunity from an infection is going to last longer than immunity from the vaccine. If anything, the data suggests it's the other way around. And we talked about the fact that the, immunity, while there is likely some residual protection against really severe disease, it does seem like the vaccines wane. We may be going to an annual vaccination situation, in which case, getting it when you're really young isn't necessarily going to prevent disease 20 years later. I know some folks, maybe back in the day, folks used to like try to have their kids get chicken pox from other kids down the street so that, they would get it out of the way. But this is really, I think, this virus really more resembles cold viruses, flu viruses that tend to sort of mutate and come back. So I think we're going to all have partial immunity. I think, from those of us who have been vaccinated or infected or both. And I think that is going to be really important in preventing the worst outcomes that we were seeing in the spring of 2020. Nobody wants to go back to that place. But I do think there's going to be, this is going to be something that's going to kind of continue to be around, and that we're going to continue to need to get, likely need to continue to get vaccinations for it, some sort of cadence, as opposed to having it be just over and done.
Great, thank you. You want to say anything about sort of what's happening in other parts of the world? I remember in the beginning when I'd be on like a conference call with our pediatric rheumatology colleagues in Italy, and things were terrible in Italy at the time. And we certainly see in the news information about COVID from all, the developing and the developed countries. Do you want to say anything about sort of what we know about MIS-C in other countries from around the world?
Yeah. So, I have not personally seen data on this from like African countries, and often, in some of our developing countries, it's harder to diagnose because they don't necessarily have the same tools at their disposal that we do. But certainly in the more developed countries, you saw that from the slide that I presented earlier, some of the first case reports really of MIS-C came out of Europe. So this was really where it started first, where those bad surges were happening. And this was where they were seeing these patients coming in with this thing that looked kind of like Kawasaki shock, trying to figure out, what was this and what did it have to do with COVID?
Yeah, it's interesting. And we can learn a lot, I think, from these different cultures and different communities around the world, and how these diseases play out there. There's a little bit more specific question, kind of drilling down on this idea of what happens to the patients who are on TNF inhibitors, especially children, and what research have we actually performed that looks at this?
Yeah, so again, we haven't really seen, because rheumatic diseases in children are rare and MIS-C is rare, we've not really been able to do research on kids with rheumatic disease when they get MIS-C, because it's just, the numbers, if are tiny, tiny. And, we talked about the fact that we haven't really seen any of those cases here at UCSF. But in terms of how these kids have been affected more generally, there is certainly a lot of good research from the adult side looking at COVID outcomes in people with rheumatic diseases and folks on immunosuppression. And we do know that high-dose steroids and rituximab, which is a biologic medication that depletes B cells, an important part of the immune system that makes antibodies, are that those individuals are at higher risk for severe disease in adults. We don't have as much on children, but as has been mentioned, we certainly have lots of anecdotal evidence because many of my patients on TNF inhibitors have gotten COVID, and fortunately to this date, they have all done well and recovered fully. And I haven't had any of them who've even had to be hospitalized. I don't know of any in our practice that have been, but definitely none of mine have.
Yeah, I agree. I think that they've been very fortunate. Well, I think thank you so much. I think we've come near to the end of our hour here, and I really appreciate the information and everybody who joined us this evening. I'm gonna share my slide, Erica, because I just want to show a little bit more information to really acknowledge the Russell Engelman Rheumatology Research Center that has been really instrumental in making this program possible. Just give me 1 second here. And so we really appreciate everybody's time. And as I said, this program is supported by Russell Engelman Rheumatology Research Center and the divisions of adult and pediatric rheumatology. So really thank them for their support. Thanks to Erica for sharing her wisdom with us, and for all of you for attending. Hopefully this was informative. I'm going to show you one more slide with some links, and this information can be sent to you afterwards. But if you're interested in learning more about the programs or offering your support, there's a link at the top here to the Russell Engelman Center and also to the divisions of adult and pediatric rheumatology. We're also going to make this available on YouTube in the next few days. So if you want to share this with friends or family that weren't available or want to watch it again, you can find it there. So thank you for being here with us this evening. Thank you to Dr. Lawson for her presentation and to all the organizers for supporting this program.